Yeah, David, I have a question. Um, the uh, the actual dominance of the SI bone data is quite, clear. Can you comment on how this actually happened? Because historically, I guess you've been in the scene for a long time and you've seen the development of SI bone. How come they were the fastest to get the RCTs internationally going? And how much of an unfair advantage may this be in the current evidence situation?
Yeah, so clearly RCTs and high-level studies cost a lot of money. And so that requires a company that can and will make the investment in evidence generation. And that's the challenge. And the US marketplace, what happened was there was a coding change that occurred somewhere around 2012 that stopped routine insurance coverage for SI procedures. That then led to the payer community that was making the decisions to say, without level one evidence, there won't be any insurance coverage and you won't be able to do the procedures. That makes it a compelling reason to proceed with generating that high quality evidence. That the challenge then is that evidence exclusive or not? And I think all we can say is that the evidence is what the evidence is. And that's like asking, what is the best vaccine to take for COVID right now? Is it the Pfizer? Is it the Moderna? Is it the J&J? And I think the answer is any of the vaccines work. The trials were all high quality trials. They compared different populations with the J&J one facing some of the emerging variants. And so they're not head-to-head studies, so I don't think we can say that one's better than the other. So in the absence of head-to-head studies, we can all express our opinion about which we think is better, but it's not data-driven. Currently, the data favors the device that's been most studied. Happy to see other emerging data, and I'd love to see improvement in the success and outcomes rates documented by high quality studies, whether they're prospective multi-center cohorts doing appropriate evaluation or whether they're head-to-head comparator studies. It's really about the quality of the data. And then after that, I can't speak to which idea is better. I can only speak to where the data currently exists. And so as we debate, I like this approach or I like that approach. I don't deny that there are a variety of reasons to take a variety of approaches, and one approach probably doesn't fix everything. But in the absence of meaningful data, it's hard to justify it, at least in the US payer community, to get it covered so that we can actually offer it to our patients. There are even insurance companies now that still won't cover triangular titanium rods with two RCTs, a prospective multi-center cohort, and up to 5-year follow-up of some of the prospectively collected data. So I think that's in part what drove it. And then the other part was a company philosophical decision to be able to and to make the investment in evidence generation.
I have a question. How long do we need to follow these types of cases when they're not true fusions and they're really relying on fixation? And I'm not saying, you can't get a true fusion with it. I've seen some picture Bates sent me. The SI bone presentation advertisement seemed to want to emphasize that, but we know from the studies we really don't see that, even the studies that have been generated by the company. So how long do you think, just based on knowledge of other orthopedic implants, do we have to follow them to make sure that they're not going to loosen over time? And I think that's a legitimate concern. I'm not saying it can't happen.
Yeah, so Jeff, that's a reasonably good question, and that I will share data and then personal experience and opinion in that order. And so the best data that we have is that there's not evidence of late loosening. Loosening when it occurs in transfixation with a bio-ingrowth device appears to occur probably in the first 3 months. And that as we look at the longer term studies, there's not a tail off in the revision, or not an increase in the revision rate. That seems to occur earlier. And the latest data that I've seen is the primary reason for revision at this point appears to be implant malposition. And I don't think we can blame the implant for that. The next issue is, does the bone heal? Well, I just had a lady referred to me from the Denver area who had had a triangular titanium rod done bilaterally, and she developed a titanium allergy. The allergy workup was done by National Jewish. They're probably as good an immunologic center as any place in the country. Defining titanium allergy is very difficult, so I'm not prepared to argue RAST studies versus other techniques for titanium allergy. But she had the implants removed on one side in the Denver area, and they couldn't get the other side out. And so they sent her to me and asked me to remove them. I can tell you that those implants were thoroughly bone ingrown on all sides at about a year, year and a half out. And that I don't know how people want to define fusion, but with solid bone ingrowth through all 3 of the implants, requiring a femoral stem extractor to extract them, that pretty much meets my definition of a fused joint. And then the last piece is, so where does the ingrowth technology come from? Well, most of it comes from total hip replacements and femoral stems. And the challenge on femoral stems is that a well-fixed femoral stem is a challenging removal as well. And that when we see femoral stems loosen late, it's usually because there's polyethylene wear debris, macrophage activation, and osteoclastic resorption at that interface. I don't see a reason for that kind of osteoclastic macrophage activation in this scenario. So I don't have a reason to suspect late loosening. And if in your comment about how long should we follow is an interesting question, because Greg Shabilsky was serving as an advisor to an insurance company, and forgive me for not remembering which one. And that originally when the 2-year clinical trial data was published, the company's response was, that's not long enough. Well, the question then was, well, how long is long enough? And they said, well, tell us at 4 years. And then at 4 years, the information was provided. They said, well, tell us at 5 years. And then at 5-year follow-up data, they said yes. And so if that's the bar that everything's got to go through of randomized controlled trials with 5-year follow-up, then that's going to really slow down the ability of innovation to make its way into the marketplace. So it seems to me that what I can comment on for the triangular titanium rods is the results at 2 years seem to be the results at 5 years.
Yeah, and that's a time frame that, we know when I just had my hip replaced, so I had to go through a lot of this. And it's not a lifetime that they'll say that these ingrowth devices will last. So, if we're putting these in people who are in their 20s and 30s and they develop osteoporosis later and they go through their life, I think there's a legitimate concern if we're not using, standard arthrodesis principles. That's just a general comment. And I just don't know how this could play out over long term. It's just something that I think we need to be not too cavalier about and not, have it as a top of the discussion.
Well, I think that that's a point of view that has a basis to be expressed. But if we said we can't fix pediatric fractures because we don't know how the devices will respond for the rest of their life, then we would be in a difficult circumstance as well. And so the question of how much follow-up is enough follow-up is a dilemma that impacts cost, rate of innovation, and access to care. And that's a difficult, challenging question that is answered payer by payer and country by country on a larger scale. And I don't know that there's a right answer. I think there's a series of choices, but not necessarily a right answer.
Right.
Dick, thanks very much. That was a great talk. The SI bone technique is a little bit different than a fusion in that you've got ingrowth into a device onto a metal spanning a joint with ingrowth on the other side with transfixation. That's different than an actual fusion of a joint where there's bone in the joint. Do you think that this 5-year period for follow-up that you've seen as the resistance point would also apply if there was an actual fusion of the joint? Which is the goal of different.
Yeah, no, great question. So how long do we need to see follow-up in spine fusions for that to say that they're healed? And how do we really assess them? Well, we try to assess them by CT scan. Is the CT scan perfect? No, I don't know that it is. And so our assessment of true bony fusion is imperfect. When it's very clear and robust, then we can all agree on it. When it's very not clear and very not fused, we can agree on it. And the phases in the middle become difficult. And so trying to quantify that becomes challenging. And it's really about, do we provide a load transferring capability to the joint, however we do it, that no longer hurts? That's the most important outcome to the patient. And that could potentially be done in a number of ways. And that as long as it works for the patient and the patient is doing better, do we really care what the radiographs look like? Well, we sort of do because we use it as a surrogate measure. But I really think that the most important piece is how's the patient doing? Because they don't come to us because my x-rays look good or bad. They come to us because they hurt.
Well, with that being said, they want to be good at 20 years later too, for a lot of these patients. That's all I need to. The concern is the long term, and especially with osteoporosis, obesity, and other spinal fusions a lot of these people end up with that put a lot of strain on there. I think we kind of, I don't want to over, discuss that, but I think it's something we just need to keep in our minds. And if it's not hard to get a arthrodesis at the same time, why not add it? It just seems like it's belts and suspenders.
Well, Jeff, I would say that nothing we do in medicine stops the aging process, and that any strategy short of visiting Tom and maybe St. Augustine in Florida and the Fountain of Youth will eventually find a way to fail. And that what is it adequate durability is an intriguing question. And that, if you've got 5-year data compared to no 5-year data, then the 5-year data is more compelling. But it's not 20, and it's not 50, and it's not 90-year data. Okay.
Conversation continues. Anyway, thanks for that great presentation.